Good morning, ladies and gentlemen. Thanks for coming to the second arrhythmia session at today's Stanford Heart Fair. My name is Sanjeev Narayan. I'm one of the new faculty members just joined at Stanford University. It's my pleasure to introduce a very illustrious panel of speakers who are going to talk about a broad range of topics in the field of heart rhythm disorders. I'm just going to start off with two things. The first thing is that many of the topics that we're going to cover were already covered in the first session this morning, so be aware of that. There are a few differences, but mostly it'll be the same. The second thing is, before we get started, a bookkeeping item. I was asked to just make sure that all of you picked up one of these brochures, and if you haven't, you can pick them up at some point. And also there is an evaluation form. So if you fill that out, we have to be on our best behavior. So I recommend you fill that one out. So the speakers that we have are Professor Vishwanathan, who has been at Stanford for some time. He trained at the University of California, San Francisco, and then around the country. And he specializes in ablation procedures for atrial fibrillation and for ventricular arrhythmias. Professor Perez is going to be talking to us about inherited conditions and how genes might cause arrhythmias and how we can detect that to improve therapy. Professor Park is going to be talking about some new treatments that are offered at Stanford that may not be available at other centers to deal with potentially dangerous heart rhythm disorders that occur in the bottom chamber of the heart, so-called ventricular arrhythmias. Linda Norton, to her right, is our head research nurse who coordinates the future therapies, if you will, that are done at Stanford, things that are not available at many centers. Some of them are available only at Stanford, that are available to people with abnormal rhythms. And finally, Angela Sipperful is our senior nurse practitioner who's going to be talking about senior inexperience, just to make that very clear, who's going to be talking about how people enter the system, how arrhythmias are treated, how people can contact the service, and so on. So, Angela, would you like to start off? Should we do it the same way we did last time?
Hello. My name is Angela. I'm a nurse practitioner with Stanford Arrhythmia Service. I've been with the service for about 14 years. Started as a coordinator and then went back to school and got my degree. I'd like to tell you that we all work as a team. We have a wonderful faculty. We have nurse coordinators, we have nurse practitioners, we have device nurses. We all work together. Sometimes we see patients first, then pass them on or refer them to our faculty, and vice versa. So we work as a team. Just wanted for you to know that. So I will be talking about who and why you would need to see a arrhythmia specialist. So first of all, what are arrhythmias? I assume you're all here because you're interested in the subject, so I will tell you what that is. Arrhythmias are basically abnormal heart rhythms. We are sort of electricians. The other room, I think down the hallway, they're plumbers, but we are interested and are expert in the heart rhythm problems. Arrhythmias occur when the electrical impulses in the heart are not produced correctly or not conducted correctly or properly. Arrhythmias are when the heartbeat is too fast, they're also called tachycardias, too slow, also called bradycardia, early or premature beats that can come either from the bottom chamber or from the top chamber, and or irregular. That happens usually in atrial fibrillation. What symptoms do patients have? Well, most patients complain of a symptom. It can be more than one. They complain of being breathless, dizziness, syncope or fainting, losing consciousness, racing, skipping, or fluttering in the chest, lightheadedness, sudden weakness, inability to exercise, and sometimes there are no symptoms. Patients come to us because the arrhythmia was diagnosed on a physical exam, a routine physical exam, in their primary care office physician. Symptoms of bradycardia include angina or chest pain. This is usually thought to be a symptom of a blockage in the heart arteries, but that doesn't happen necessarily in that case. We have patients with abnormal rhythms who have chest tightness or symptoms of angina. Some patients have problems concentrating. Some are confused. Some have difficulty exercising, dizziness, fatigue, lightheadedness, palpitations, shortness of breath, syncope, or no symptoms at all. You probably noticed that symptoms of too fast or too slow are sometimes the same. So it's hard to tell just by looking at symptoms. So what we do is we have several tests that are available to us to diagnose arrhythmia. Patients generally come to us sometimes when they have a diagnosed arrhythmia or when they have an undiagnosed arrhythmia. So an EKG is the simplest test that we use a lot in our practice. It shows us what the rhythm is and the pattern of the rhythm in that period of time when we check the patient, within that 6 seconds that we check that rhythm. It gives us a lot of good information, but if you don't have symptoms or arrhythmia during that very moment, then we're not able to record it and therefore not able to diagnose it. So we have other means of doing that, and those are different kinds of Holter monitors. There are 24-hour Holter, 48-hour Holter. There are longer period Holter monitors like a Zio patch monitor I'll show you later. And there are event monitors. Depending on how frequent symptoms are, we use different modality to diagnose it. We also use Holter monitors or event monitors to evaluate how appropriate and how well the treatment is, how well the medications are working. If we give you medicine to control the heart rate, we can then check a Holter monitor if it is indeed doing what we asked it to do. Is it enough of the medication? Do we need to increase the dose? Okay. In some patients, symptoms are so infrequent that we need to use an implantable monitor. It's a very small device that gets implanted under the skin and stays there for 2 to 3 years and monitors your rhythm all the time for 2 to 3 years. We have patients who have syncope maybe once a year. They have fainting episodes maybe once a year, and it's very hard to catch it with irregular monitoring devices. So this is what it's used for. This is just an example of what the monitors look like. And the one at the bottom is what I was referring to. It's called the Zio patch. It was developed at Stanford, actually, and it is a Holter monitor, essentially, that is placed on the chest for about 2 weeks or so. The beauty of that is that it records every single heartbeat while you're wearing it, and you don't have to take it off in the shower, which is a case with other monitors. Other tests we use are blood tests that check the liver, thyroid function, electrolytes, and kidney function. These tests are used to both determine the potential cause or trigger of atrial fibrillation, as well as to determine which medications we can start a patient on. An echocardiogram is an important test. It's, again, a non-invasive way. It's an ultrasound of the heart and a non-invasive way to look at the heart function, how well it squeezes, heart valves, and a heart chamber size, which is also very important in diagnosis and management of atrial fibrillation. We often use a sleep study. Sleep study diagnoses sleep apnea, which is a common cause and trigger of atrial fibrillation as well. So when you come to see us, it's important, it's a partnership. When you come to see us, you want us to tell you what's wrong and how to deal with it. And we're interested in asking you all these questions that would help us to get to the diagnosis. So maybe to prepare answers to these questions before you come to see us would make for a more effective visit. So questions to think about is, when did your symptoms begin? Do you have symptoms all the time or occasionally? How severe are your symptoms? What helps, what works, what stops them? What makes your symptoms worse, or what triggers your symptoms? Description of your symptoms, frequency, what are you doing when it happens, how long they last, what medications work, or what works to stop it. And it also is very helpful if you can bring the list of medications with you so we can see what you're taking currently. Thank you very much for your attention. We'll all be here after the lecture, and please write your questions on the notepads we gave you, and we'll be very happy to answer your questions at the end of the talk.
Thank you so much, everyone, and thank you, Dr. Narayan, for the kind invitation to speak to you today. And it gives me great pleasure to speak to you today about atrial fibrillation and a little more about how we do treat it. How do we actually use medications, and often how do we use catheter ablation to actually mitigate the symptoms, and not only that, mitigate some of the downstream side effects and complications and whatnot that may develop with this condition. And again, I wanted to just reiterate here that our faculty members, some of whom you'll see today on the committee, but by and large, we have our committee here today, or our panel, I should say, and I want to reiterate what Linda Norton had spoken about earlier in the last session, is that this is a team effort. And again, Angela also spoke of it. We work together with nurse practitioners, nurses, medical assistants, and all of our faculty members, really to tackle these cardiac arrhythmias, one of which is atrial fibrillation. So with that, let's get started a little bit about what we feel at Stanford really is our mission and how we do what we do. So really, I think it's important to bring this up, and that is, really, what are we here to do? We're here to, and we're dedicated to delivering outstanding and compassionate care for arrhythmia patients, along with our colleagues in cardiology as well, while working with their physicians, primary care physicians, and trying to really advance teaching, research, and clinical care here at Stanford. And again, we really appreciate, and we really do very much value the trust that your physicians and yourselves have given to us to take to partner with you in taking care of your health. So our vision, again, is that we in the Cardiac Arrhythmia Group really would like to be recognized as one of the top programs in the nation. And I feel with our group growing and some of the things we're able to offer here at Stanford, I would think that in the next, even now as well as in the coming years, we would be considered in that group. And we focus on delivering the state-of-the-art arrhythmia care and try to be as best as we can innovators and leaders in this field. And with that, I'd like to start in on some of the things that we do on a day-to-day basis. So what do we do in electrophysiology? And then we'll get into atrial fibrillation. So one of the things that we're focusing on today specifically is catheter ablation of atrial fibrillation. We do catheter ablation, the delivery of radiofrequency energy or cryo-energy, a freezing of regions in the heart to basically mitigate atrial and ventricular arrhythmias, so abnormal heart rhythms, electrical signals that have gone awry, and try to reestablish what is thought to be the regular rhythm or sinus rhythm of the heart, which you all know day in and day out is that regular cadence of your heartbeat. We also, when it comes time to situations of investigating arrhythmias, be that they may not be appearing all the time, we do specific testing for arrhythmias, and Angela, our prior speaker, spoke on how we try to identify those arrhythmias with monitors and invasive studies if needed. We also implant pacemakers, defibrillators. We actually do also extract leads and these devices in the event of infections, and also we provide consultation. Day in and day out, not everyone that we see requires a lot of these treatments. However, we would hope that we would provide prudent assessment of anyone we see in terms of who is a good candidate and who needs other types of treatments. So again, let's focus in on atrial fibrillation, our challenge for today. What is atrial fibrillation? Now, many of you will already have known exactly what we're talking about, but what is it? Well, what it is a rapid rhythm. It could be an irregular rhythm, may not be as rapid, but it arises in the upper two chambers of the heart, the right atrium and the left atrium. As you know, our heart is made up of 4 chambers and valves as well as vessels that arise outside of the heart and feed into the heart. And so atrial fibrillation is a chaotic, irregular heartbeat that arises from irregular impulses that are being generated in the upper chambers, and what it ends up developing is to the sensation of an irregular heartbeat. It can be rapid, it could be at times quite slow as well. However, that is what would say the definition of atrial fibrillation. Now, we have some categories that we use. Now, what about this entity? What do we know about the prevalence of atrial fibrillation? How many people do develop this condition? Well, these are estimates based on a number of studies that have already been done by the American Heart Association. Even our colleagues in the Bay Area at Kaiser, Dr. Goh and his colleagues really have put together large databases to identify what is the trajectory of atrial fibrillation. And you can see here that currently, actually this is dating back to 2004 really, 2.2 million people were affected by atrial fibrillation. And this is projected to grow to about 5.6 million by the year of 2050. So it's really definitely, and this is the United States, it's definitely a worldwide issue as well. So we're really looking at an entity that we as physicians will be seeing more and more, and we'll really have to come up with the best strategies to tackle. So the incidence is thought to be about 0.1% per year in individuals less than 40, about 1.5 to 2% per year in women and men above the age of 80. So really, as years go by, it is definitely something that many of us will have to be dealing with. Again, the risk of stroke is about, this may be a little bit of an overestimate, it's about anywhere from 1 to about 4 to 5% per year, and that's really upwards of 2 to 6 times that of those individuals without atrial fibrillation. So really, this is one of our major concerns. How can we mitigate really and reduce the risk of stroke that individuals face with atrial fibrillation? The mortality it's quite significant. How do people actually, how in the setting of atrial fibrillation does that increase your mortality? We're still trying to grapple with that. Is it all from stroke? Is it just from its attendant cardiac conditions that maybe atrial fibrillation is more of a marker of an underlying condition? These are things that we're trying to investigate here at Stanford as well. So what about, how does AFib break down in terms of age groups? Well, as you can see here, the dotted line shows the U.S. population in general. So there's a peak in the relative. This is actually studies from the 90s, but there's a peak of U.S. population in the mid 30s or so, and in general, the population does dwindle as the age increases. However, what you can see here is that the actual incidence as well as the prevalence of atrial fibrillation does go up in the later years. So as you can see here, there are definitely individuals who are afflicted with atrial fibrillation in the 30s and 40s. It's not really a condition seen in the pediatric population. However, it does increase, and by the age of between 75 and 79, that's the latest condition. So I'm sorry, that's the largest subsection in age group that really you'll get the increase in atrial fibrillation prevalence and incidence. So what about certain things about how do we categorize atrial fibrillation? There's paroxysmal atrial fibrillation. That's a term we use for individuals with atrial fibrillation that comes and goes. Really, you're not in atrial fibrillation all the time, but really there are periods in time where you have atrial fibrillation and other times when you're in sinus rhythm. Persistent atrial fibrillation is a specific term we use quite frequently, and that is recurrent episodes that last more than 7 days. And usually this requires a electrical cardioversion, where we actually deliver an external shock to the heart to reset the rhythm back to sinus rhythm. And permanent AFib, or another term we use is chronic AFib, or long-standing persistent AFib potentially, is an ongoing long-term condition. This is a situation where cardioversions have been attempted and potentially the arrhythmia has reverted once again back to atrial fibrillation, and we're getting to a point where we may or may not be able to really curb and get rid of the arrhythmia, but it's a matter of managing the arrhythmia. The spectrum of atrial fibrillation, like we talked about, there's usually a progression. There's usually a progression from being intermittent or paroxysmal, where this type of arrhythmia comes and goes, the irregular sensations, and that's usually associated with less structural abnormalities of the heart. So we talk, LA here is left atrium. So when the left atrial size is less than about 5 centimeters in the in one dimension, that usually results in situations of early onset AFib where it's intermittent. And this seems to progress to the point of long-standing persistent. Now, individuals can be along the continuum of AFib anywhere along those lines, and these periods are not linear by any means. So what I wanted to say is that people can be in any of these stages for any bit of time, but nevertheless, we do see a natural progression. So again, we're talking about an arrhythmia that is very rapid in the upper chamber, but what we see here is that it may not result in heart rates that are in the range of 200, 300 beats a minute, even though the atria may be contracting at that rate. What we see is that central part of the heart, there's a node or a way station that is responsible to transmit the impulses from the upper to the lower chambers. And in atrial fibrillation, the AV node basically tries to act to mitigate or reduce the rates at which the heart will beat on the lower chambers and really cause a heartbeat. And that is how we all, if we're in atrial fibrillation, we don't really pass out immediately, because this way station is so important to our ability to handle atrial fibrillation, at least when an individual is in the arrhythmia. So we use medications actually to reduce the ability of the AV node to transmit these beats in order to allow more of a heart rate that's more akin to what we're used to, about 60 to about 120 beats a minute. And in atrial fibrillation, in individuals that we're just trying to control the rate, we use agents such as digoxin, beta blockers, which you may have come across, metoprolol, atenolol, propranolol. We also use calcium channel blockers. These are agents such as diltiazem and verapamil that maybe some of your physicians have used in order to actually reduce the rate at which these rapid, irregular heartbeats are transmitted to the lower chambers. And that is one method of treatment of atrial fibrillation, just controlling the heart rate. Now, that applies more in individuals who potentially attempts at trying to get rid of the atrial fibrillation either have failed, or there are some issues in certain individuals where those strategies have not, cannot be attempted or have not worked. So this gets to the point of how do we categorize our treatment options for individuals. So there are, in our field, there's two ideas about how we manage atrial fibrillation. One is what we talked about, rhythm control. Can we actually restore the heartbeat and the heart rhythm back to normal, to sinus rhythm? And so this is predicated on this idea that normal sinus rhythm really is better for our hearts, for their performance, for their long-term durability and whatnot. There are pharmacologic and non-pharmacologic approaches. Namely, the non-pharmacologic approaches are that related to catheter ablation, which we'll talk about. The other approach is rate control. So once we've gotten to a stage, what we talked about, where we may have to accept atrial fibrillation, our main goal here is to control the heart rate and make sure that individuals can really tolerate the arrhythmia, but nevertheless get it to a range where it's more in keeping with what we're used to seeing in our day-to-day lives. Can we do activities and function appropriately even though we have atrial fibrillation? And I would want to reiterate here that, again, no matter what approach you take, the undercurrent is that we have to mitigate stroke risk in either of these approaches. And that gets to the point of anticoagulation therapy that my colleague Dr. Park had talked about prior as well. So what kind of questions do we ask about when we look at each patient? these are just some things we talk about. How symptomatic is the patient? How persistent is the atrial fibrillation? What about the pumping action of the heart? So in preference of time, I think I'm going to go, we talked a little bit about rate control strategies of these medications. These medications, again, are targeted at controlling the rate, which we talked about earlier. We would not use our next category of medications, which are antiarrhythmic drugs. Now, these medications, which you may have come across, really are the agents that we use to actually control the rhythm. So once we reset the rhythm with a cardioversion or perform a catheter ablation, we use medications such as flecainide, propafenone. There's about 6 agents: sotalol, dofetilide, amiodarone, or dronedarone. These agents are antiarrhythmics. Their goal is to maintain the rhythm as sinus rhythm. Again, we talked about prevention of stroke. I'm not, in interest of time, we'll cover this later, but we use a scoring strategy to see how do individuals, how can we assess their risk of stroke, and based on some of these comorbidities such as congestive heart failure, hypertension, age, diabetes, prior history of stroke, we use those co-conditions along with atrial fibrillation to make decisions about blood thinners and that type of, and these include warfarin, our tried and true anticoagulant, as well as some of the newer agents that you may have come across: Pradaxa, Xarelto, Eliquis. Edoxaban, a newer agent, really just has been approved in the United States, so we really, I have not seen the agent yet, but you may be seeing some of that in the future. Now, what about catheter ablation? I'm going to take a few minutes here, just talk, as some of my colleagues will also be covering this type. So what is catheter ablation? So through a percutaneous approach, we actually deliver catheters up the venous system, up the inferior vena cava into the heart, and actually cauterize areas of atrial fibrillation. And what this entails is, this is just a diagram of the left atrium, and you'll see here there are 4 pulmonary veins that drain into the left atrium, and it's thought to be that this is an internal view of those pulmonary veins. This is the junction between the vessels that drain blood from the lungs back into the heart, full of oxygen on the way out to the brain and the legs to provide oxygen to the body. It's in these, we think that it's in the mouths of these veins on the inner surface where some of the triggers arise for atrial fibrillation. And what we deliver is basically a ring-like treatment around the mouths of these veins. You could consider it as an electrical barrier around those. Nothing is left in the heart, but just the remnants of what basically creating that electrical barrier. Now, my colleague Dr. Narayan has really innovated a strategy as trying to find other areas that really may be integral to the development of atrial fibrillation outside of these pulmonary veins. And at Stanford, we're employing these types of strategies to really improve our techniques. So in general, I want to give you a little bit of, we think this strategy works for a lot of individuals. The success rates have been smack dab in the 60 to about 75–80% range, but we really have not been able to push that beyond that. However, with the advent of this type of mapping strategy that Dr. Narayan will be talking about, trying to find other areas, we've been able to push the envelope a little bit above 80%, but it's still an area that we feel at Stanford and across the country that we wish we really had a little more understanding, and in time we very well will. So in general, let's just summarize as my colleagues will go over these. The reason that people really want to move forward with catheter ablation, and we get to that point in individuals, is that when we do catheter ablation and we reset the rhythm back to sinus rhythm, people feel better. And that's really the main reason we undertake these strategies. We yet don't know what the best strategy is for every individual. And as such, that's why we go back to those questions we ask everyone. Really, what's the best strategy for each individual? So I want to leave you with some of these take-home points for management of atrial fibrillation. We talked about rate control strategy, so just mitigating the heart rate in atrial fibrillation, trying to just make people feel better with the heart rates. But in some individuals, we want to use antiarrhythmic drugs to reset their rhythm. Ablation, taking the next step, trying to really have a more durable and long-standing benefit of trying to reset the rhythm to sinus rhythm is a strategy for more and more individuals. And again, the important idea is to keep in mind is that we want to really reduce the stroke risk in any individual that we see with atrial fibrillation. So thank you very much. Again, I want to leave you with the phone number, and happy to take questions throughout the course. We'll try to focus at the end as well. Thanks so much.
Thank you very much, Mohan, for that wonderful overview of the program. We really are a full-service electrophysiology program, and not only are we dealing with all sorts of arrhythmias and heart rhythm problems, but we are actually pioneering some new approaches that we're going to be discussing. We have discussed and we'll be discussing over the next half an hour, 40 minutes of the program. So picking up from where Dr. Vishwanathan finished, atrial fibrillation is a very common problem. Many people don't feel it. Some people have just a few occasional skips or beats. It doesn't really cause problems in the large number of patients, but it does need to be detected and treated the same way you might treat other heart conditions, other kinds of problems such as high blood pressure. What we're going to talk about is what is the best way to treat patients. So we know that atrial fibrillation now is somewhat of a lifestyle change. If you look back over time, you can actually see that there are many things that have caused the progression of atrial fibrillation over time. One of the trends is this trend. It's not so much this trend over time, actually. It's actually the progression into this. Now, having trained in St. Louis, Missouri, I can tell you I saw a lot of this. My wife would tell me this is far less common among women, and this is the evolutionary strategy that she seems to prefer. So we know that a large number of patients can get a tremendous relief from all of the heart rhythm problems as well as general health by taking standard lifestyle measures. Obviously, exercise within moderation, and Dr. Perez will be discussing that. Losing weight has been shown directly to reduce and reverse amount of atrial fibrillation that people have. Women obviously don't have this problem, but in general, are there things we can do beyond lifestyle? Dr. Vishwanathan mentioned drugs. Many of our patients do very well with simple medications that might be used already for their blood pressure control. There is a point, however, where certain individuals have a large number of problems, may have symptoms, and at that point, catheter ablation has a role. What exactly is catheter ablation? Well, as Mohan discussed, it's a way of taking people from their AF back to a normal rhythm. What's a normal rhythm and what's AFib? You don't have to be an expert to see that in this ECG strip or EKG strip, on the left you've got a fairly regular set of beats. Each of these beats will give you a pulse at the wrist. And over to the right, it's really irregular. So this one on the left is normal or sinus rhythm. This one on the right is atrial fibrillation. AFib gets started by an extra beat or extra beats. We call them triggers, which often lie in regions of the heart called the pulmonary veins. So the standard procedure, which is very effective in many patients, is to eliminate those triggers. As Mohan described, the heart has 4 chambers. The ones at the bottom here are not the ones that are affected by AFib. You can see here on this slide that the bottom thicker chambers are what give you the pulse, maintain your blood pressure, and keep us all going. Those are usually normal in patients with atrial fibrillation. What we're dealing with, therefore, is not something you need to panic about, but it is something that needs to be treated. The triggers in atrial fibrillation arise in this region of the left atrium called the pulmonary veins. So the standard approach is through a groin blood vessel, pass a catheter, which is just a thin flexible tube, up into the right atrium, poke a little hole carefully from the right to the left, and then cauterize around these veins. How effective is that procedure? It's actually very effective in many patients. You will often see quoted numbers of 70 to 80%, and you can often achieve that. One of the ways that we are struggling, though, as a group is, can you achieve that with a single procedure? Because, in fact, if you look at a single procedure, the results are a bit less. Here you have a standard success curve. It's called a Kaplan-Meier curve. On the left, on vertical axis, you've got success rates. Up there is perfect, which we all strive to be, and down here is where nobody wants to be. Okay, so you want to be as high as you can over time. So on the day of the procedure, that's a success. So we would like, ideally, the success rate to stay at that line of 1 over time. Unfortunately, perfection is difficult to achieve, and so people tend to recur with AFib over time, and after one procedure, the success rate at 1 year is somewhere in the 50 to 60% range. So how do we get to the 70-80% number? By actually doing additional procedures. I mean, some people would often get a success when they have a second procedure, and occasionally a third is needed. In that way, you can get to a success rate that's very respectable and really treats and alleviates symptoms in a lot of patients. How do we get those incremental success by doing additional procedures? What do we do? What we typically do is we would look to see if the original ablation results held, in other words, whether the pulmonary vein areas have been adequately isolated. But in addition, we would look to do ablation of other areas in the heart, as Mohan discussed. What other areas? That is currently on the cutting edge of our field. There are people that think that nerve cells in the heart are important. They might target them. There are some people that think there are little rotating spirals in the heart. We call them rotors, that may be important. Some people target them. And additionally, there could be little spark areas, a bit like a pulsar in a night sky, that could be triggering or sustaining the rhythm, and some people treat them. The problem has been, until recently, how do you find each of those? And in fact, the tools to find each of those areas outside the veins have been lacking. So one of the things that our group at Stanford has been instrumental in developing is ways to actually map that. Some of this information has been available to us for some years, and we just haven't been able to pull it together. So this is a quote from Mark Twain. "When I was a boy of 14, my father was so ignorant I could hardly stand to have the old man around. But when I got to be 21, I was astonished at how much the old man had learned in 7 years." So a lot of information has been available, and we just haven't had the wherewithal to pick it up. Over time, we're seeing a lot of things that actually starting to pull the field together. I'm going to illustrate this with a case that really got us moving in the direction of finding localized regions outside the veins that may sustain AFib, that can be offered as a treatment. So briefly, this is a 47-year-old gentleman with a lot of atrial fibrillation. Basically, he was going to the emergency room almost weekly to have treatment. He had some other issues that were under control, high blood pressure. On examination, he was fine. He'd actually had an ablation already. It worked a bit, but not very well. He was still going to the emergency room. Then he had a second and a third. So by the time he came to us, the question was, what more can we do? Is there some way we could... This is a patient who is relatively rare in that they haven't responded to AF ablation, pulmonary vein isolation very well. Is there something else we can do? We took the idea that maybe, like a storm, which appears very complicated if you see the rain hitting you from the north and the south, maybe that, just like the storm is often caused by a localized center, shown here, maybe the complicated rhythm of atrial fibrillation is also sustained by localized areas. So we set out using a system that we developed to actually map areas outside the veins. And this is what we found in his case. We went into the right atrium with this system and found this spinning top. I hope you can see that, this yellow counterclockwise wave, which we call a rotor. We ablated in that area and got a very good result. In fact, this is another way of showing that rotating spinning top, and we can see that ablation was actually conducted here. The total amount of ablation was actually very low. It was only 6 minutes. Now, obviously, he's one of our best patients, which is why I'm showing him at this morning's session. Not everybody's treated that quickly, but it's proof of concept that you can get a very good result by looking at areas outside the pulmonary veins. Not only was the procedure a success, but over the next year, the patient did very well, lost weight, went back to work, and so on. So, is that it? Are we done? Well, I think you have to be a little bit skeptical. I think, from Mark Twain again, truth is stranger than fiction, but it's because fiction is obliged to stick to possibilities, truth isn't. Another way of looking at that is also from one of his quotes, "Be careful about reading health books. You may die of a misprint." So, is there basic science to support this, and what do other groups say about this sort of approach? there actually is basic science going back about 25 years, showing in basic models like computational models and certain animals that in fact you can see these localized spinning tops. This is an activation wave which is going around and around in a very organized fashion from red to blue, and around it is chaos, like the corona of the sun. Again, it's the eye of the storm analogy. So this had been shown in basic work for some time, that in 2011 we put together a series that we presented and then published showing that in fact you can see this in humans. And this is another way of showing what I just showed you in that first seminal case that we did back in 2008. So how does this work in general? I'm going to actually skip this except to say that the overall results are in this slide, which are that using the same sort of Kaplan-Meier curve, where this will be a perfect line, which unfortunately we haven't achieved yet, and this will be nothing, you can see that if you do a standard pulmonary vein isolation, one procedure, you get this result, and if you add this procedure we call FIRM, F-I-R-M, the results can go up. Again, not perfect, but substantially better in our experience and many other groups who are trying this. Just for comparison, this will be a good group in France who started the field of AF ablation, who have success rates that are sort of in line with the standard procedure. And in patients like this who've already tried and failed drugs, it's no surprise that if you go back onto another drug, the success rates are somewhat lower. So, in summary, AF ablation is a very effective procedure in many patients. Patients who typically have already done things like try to lose a bit of weight, try to exercise, and try a couple of drugs, as Dr. Vishwanathan said. In some patients, PVI doesn't work, or you need 2, 3, or more procedures. In many of those patients, it may be worth trying something different, and firm mapping is something which is now available commercially, and many groups are actually trying this. It was developed by our team, and we found that patients often have a few of these sites, we call them rotors or focal sources, that can lie anywhere, often in areas that wouldn't normally be targeted by a standard pulmonary vein isolation. And therefore, we've typically been adding it to a pulmonary vein isolation procedure, and it's been showing good results in early trials. I'd like to just say that there are many resources available. AFib is a relatively complex disease. We're still on the cusp of learning it, and there are websites such as stopafib.org that I've put up here that are well worth a visit, as well as sites that Linda Norton will be discussing later, and of course the Stanford resources. So with that, I'd like to thank you very much, and then we'll move on to the next talk. Thank you. So we're actually going to switch gears, and I'm going to invite Dr. Shirley Park to talk to us about ventricular arrhythmias, which are rhythms that come from the bottom chambers of the heart. Let me get you started here, Shirley. Dr. Park trained in Harvard and then completed her training at Stanford, and she has been on faculty here for some years now. And somehow I'm having trouble with this silly interface. I've got it. There we go. I usually do it this way. Brilliant. Thanks.
Thank you and welcome again. Thank you for coming. So we are going to shift gears. We're going to talk about a completely different type of arrhythmia, or group of arrhythmias called ventricular arrhythmias. So what are they? So arrhythmia just means abnormal heart rhythm. And ventricular arrhythmias are abnormal rhythms that arise from the lower chambers of the heart, which are called the ventricles, and that's why they're called ventricular arrhythmias. I sort of split them up into 3 main groups. The first is something called a premature ventricular contraction, or PVC, and I'll talk about each individual one a little bit more. So there's another one called ventricular tachycardia, or VT for short. And then there is ventricular fibrillation, or VF for short. Since those are mouthfuls to say, I'm going to use the acronyms if that's okay. So a PVC. A PVC is a single early beat that comes from the bottom chamber of the heart. So if you look at this bottom, this is an EKG rhythm strip. This is a normal beat, this is a normal beat, and then you see this, which first of all looks very different. and then comes early, as you can see. It's a little bit closer to the last normal beat, and then you have a normal beat that comes back. And that's kind of what it looks like, essentially, if you conceptualize. It's this little firing from the bottom chamber of the heart. Ventricular tachycardia is a fast rhythm, so more than 100 beats per minute, that again arises from the bottom chamber of the heart. There's two main mechanisms of how ventricular tachycardia occurs. The first one is when there's a small collection of irritable cells somewhere in the bottom chamber of the heart that just starts firing very rapidly, like that. And every time it fires, it makes the bottom chambers activate or squeeze. And so it can make your pulse fast, because every time your bottom chambers squeeze, that creates the pulse that you feel. The second mechanism is essentially a short circuit that leads to a loop of electrical activity which encircles a scar in the heart tissue. The scar is usually from a prior heart attack, and it looks something like this, where the circuit just goes round and round that little area of scar. Both of them can essentially cause the bottom chambers to beat very rapidly. And lastly, ventricular fibrillation. So this is when you have very rapid, so greater than 300 beats per minute, disorganized electrical activity in the ventricles. It's kind of like an electrical storm in the ventricles. And that is not compatible with life. Essentially, that is the most common rhythm that is a cause of cardiac arrest or sudden death. So, what are the causes of each of these? So PVCs can actually happen in normal hearts, hearts that don't have any other problems, and it's just this electrical abnormality that causes these little beats to come in every once in a while. They can vary in frequency. Some people it's very infrequent. Some people it's very frequent. You can also see them in the setting of underlying heart disease, so having had heart attacks in the past, or heart failure where you have a weak heart, or congenital heart disease when you have structural abnormalities in the heart that develop while you're in utero as a fetus during development. So I kind of grouped VT and VF together because oftentimes their presentation and the way we treat them is very similar. So the causes of VT and VF, they are much more commonly associated with underlying heart disease. So having had prior heart attacks, heart failure, again, weak heart. Other common causes are actually, paradoxically, antiarrhythmic medications. These are medications that are supposed to be suppressing abnormal rhythms, but a lot of them, they have a side effect of actually producing other arrhythmias, specifically VT and VF. Electrolyte disturbances, those are things when the levels of potassium or magnesium or calcium are out of whack in your blood. Ion channelopathies, those are inherited disorders that can predispose you to abnormal heart rhythms, and I think Dr. Perez will speak more about that in a little bit. And lastly, you actually can have VT or VF in a normal heart, or at least in a heart where we can't seem to find anything else wrong other than this electrical activity. So what kind of symptoms would you get with these types of rhythms? So for PVCs, PVCs can oftentimes not create any symptoms. And I suspect that almost everybody has PVCs. It's just a matter of whether you feel them and how many you have. But when you do have symptoms, they will often cause, most commonly, palpitations. So that can just be either feeling like your heart is irregular and not, flip-flopping. Some people feel it as a skipped beat or a pause, where you can, you feel like all of a sudden your heart didn't beat, didn't go. Some people feel it as a strong pounding sensation in the heart. Other associated symptoms are dizziness or lightheadedness, or sort of this pounding or full sensation in the neck. I've heard that as well. So for VT and VF, symptoms are also palpitations, slightly different in nature. These are more fast rhythms. They will often cause you to feel like your heart is racing or fluttering in the chest. Definitely can be associated also with dizziness and lightheadedness. Chest pain, especially if you have underlying heart disease and your heart is going faster than it should be. Shortness of breath. And lastly, and most seriously, loss of consciousness or cardiac arrest, basically, sudden death. So how do you treat these? So for PVCs, there are medications that you can use. That's the most conservative route. Beta blockers, which I think Dr. Viswanathan mentioned, which essentially slow the heart down, but it calms down that little irritable focus that fires, or other types of antiarrhythmic medications, or catheter ablation. There is an ablation for PVCs. For VT and VF, again, medications, probably the main, the first line therapy. Something called cardioversion or defibrillation, which I'll talk about in a little bit. An implantable defibrillator, which I will also talk about in a little bit. You can also do an ablation for VT. Excuse me, that's a typo. Loss of consciousness is not a treatment. Sorry. Cardioversion defibrillation. So as was mentioned, that's the idea of getting rid of any arrhythmia and restoring normal rhythm. And you can do it two ways. You can do it electrically with a shock to the heart, or you can do it chemically as well. Sometimes you can just administer a medication that will actually terminate the rhythm and get you back to normal rhythm. So in some patients who have a higher risk of cardiac arrest, in particular having maybe recurrent cardiac arrest episodes, you can actually implant a device in the body called an automated implantable cardioverter defibrillator. We say ICD for short. And that's a device that sits in the heart and in the chest wall, and it can detect rhythms like VT and VF, even if you're not in the hospital or are not on a heart monitor. It does it itself. And then when it says, oh my goodness, you're in VT or VF, it can actually give you a shock from inside the heart. It's the same idea as defibrillation or cardioversion, but from within the heart, and can actually abort cardiac arrest. And lastly, catheter ablation. So again, catheters are these small plastic tubes that you insert into the heart, and ablation is the killing off of these islands of cells to treat a heart rhythm problem. So for PVCs and certain types of VT, all you need to do is target where the rhythm is coming from, and then you can potentially get rid of it with your catheter. When should patients have a catheter ablation for these arrhythmias? So for PVCs, I would say if you are very symptomatic, in particular, if you're not tolerating medications or medications aren't working, it's definitely an option. And for VT, again, if your medications are not working or you're having side effects, or if you're having so much VT or that you are getting shocks recurrently from a defibrillator or needing to get externally defibrillated, it's definitely an indication for catheter ablation. And that is actually the last of my slides. Yep, thank you very much.
Thank you very much, Shirley. So just to continue the trend of atrial and ventricular arrhythmias, the fact that heart rhythm disorders can be very broad, it's my pleasure to introduce Marco Perez, who hopefully can find his own slides, because I'm having trouble. Is it right in front of me?
No, it's
That's what my wife is always saying. Directly, there it is, brilliant. Which is a topic that's, in a lot of, really in the public consciousness of, are there ways in which heart rhythm disorders can be inherited, and can we use those to design new treatments?
Well, thank you everybody for being here on your Saturday morning, and I've been asked to speak about arrhythmias or irregular heartbeats that can happen when you're an athlete, and we've heard a lot today from the speakers about the different types of arrhythmias, and I want to speak to you about some of the unusual arrhythmias that we see in young folks and people who are athletes. Now, if I can say one thing before I get started, it's that exercise is good for you. So I don't want you to walk away thinking that if you do exercise, you're going to get arrhythmias and that you should avoid exercise. In fact, we and others have done several studies that have shown that exercise decreases your risk of atrial fibrillation, of heart attacks, and so forth. So don't get I hope you don't get the wrong message. But I'm going to be also talking about some of the unusual arrhythmias, some of the rare arrhythmias. And not so much because many of you will have these, but you might find that in your families, some folks in your families have these arrhythmias. Sometimes, I get approached a lot after these kinds of talks saying that, a relative of mine died suddenly, or a relative of mine who was very young, had one of these conditions, and these are the types of families that we really like to speak to, because there are certain types of tests that we can do to screen for some of these conditions, and our hope is that we're able to detect these very early on before they cause any problems. So, many of you might know the story of the first marathon, but this was when the very first documented episode of somebody dying suddenly after an athletic event. So in 490 BC, after the Greeks defeated the Persian army, Philippides, who was a messenger, a Greek messenger, ran to deliver the message from Marathon, which was the village in Greece, all the way to Athens. And that was a distance of about 26.2 miles, which is the marathon distance of today. He was able to get there, deliver his message, and in all the excitement, and after the long run that he did, he actually collapsed and he died suddenly. So that was the very first episode documented. And very sadly, we see this even today. And as a society, I think this is one of the saddest things that we experience when we have a beloved athlete, somebody who we admire, who we think is the epitome of health, suddenly dies, and sometimes right in front of our eyes. It's quite a tragic event. So it's not something that's common. There are lots of different estimates about how often this happens. It's probably on the order of about one in every 20 or 30,000 athletes. So not very common, but again, when it does happen, it's something that's quite tragic. And the question is why? Well, how does this happen to our what we believe are very healthy athletes? And the answer, I think, falls into two main categories. So two really main reasons why an athlete can die suddenly. One of the main categories is due to a condition or a series of conditions that can affect the heart muscle itself. So often some of these athletes are born with an abnormality in the heart muscle, and in one of the most common causes, which is hypertrophic cardiomyopathy, what happens over time as the athlete gets a little bit older is that the heart muscle itself gets thicker and thicker, and often we can start to see scarring in the muscle. And these scars can predispose you to some of the conditions that Dr. Park talked about, which are the ventricular arrhythmias, ventricular tachycardias, ventricular fibrillation. And that can be triggered by exercise. And so that's why we see sometimes on the basketball court athletes dying suddenly. The other big group of conditions that can cause you to die suddenly are not conditions that are easy to detect. In fact, if we do an ultrasound or some other kind of imaging study, if we were able to look at the heart itself, it would look absolutely normal. What's happening here, however, is that there's an abnormality in the electrical system of the heart. So the machinery that makes up the electrical system of the heart has an abnormality, and that can then predispose you to some of these irregular and dangerous heartbeats. So those are the two major categories, and there are several conditions within each of those categories that can lead to atrial arrhythmias, like the arrhythmias that Dr. Viswanathan talked about, like atrial fibrillation, or more dangerously, it can lead to the ventricular arrhythmias, like the ones that Dr. Park talked about. Now, we do believe that in the older folks, these arrhythmias tend to happen because you've lived a long life being exposed to things like McDonald's and smoking and lots of other things that can cause your heart over time to become bigger or scarred. But when this happens in somebody who's young, who hasn't been exposed to this all of their lives, this is almost always due to a genetic abnormality. Now, think of your genes as instructions. Okay, so everybody's born with a slightly different set of instructions that tell the body how to create each cell, how to create the tissues, and how to create the different organs in your body. Now, when there are abnormalities, when there's the abnormalities in the instructions, when there's a misspelling in the instructions, then the body has a difficult time creating the machinery that it's supposed to build, and some of those abnormalities can lead to these dangerous heart rhythms. So the big question is, how can we find this before it causes any problems? This is particularly important in athletes because we know, we see that some of these athletes can die suddenly during their exercise. So we want to do everything we can to prevent these episodes from happening. And some of the very, very easy things that we can do to help prevent this are just to talk to the athletes. To ask them about their families, ask them about their own histories. Do they have somebody in their family who died suddenly? Have they ever passed out suddenly? Those are the types of questions that are really important to try to identify these athletes early on. What's a little bit more in debate right now is whether or not we should do certain types of tests to see if these athletes are at risk for dying suddenly. So we and others also study the electrocardiogram to identify different findings that might predispose an athlete to dying suddenly. And what we do is we look at the little squiggles on the electrocardiogram, and if those little squiggles look different from what a normal electrocardiogram could look like, then at that point we might recommend more testing like an ultrasound or other types of imaging of the heart. So we at Stanford now have a growing group of cardiologists who are interested in evaluating athletes. So certainly if ever there is an abnormality in one of these electrocardiograms or a family history or anything like that, then we're more than happy to talk to the athletes about further testing and about their family's genetics. And if we do find one of these genetic conditions, then we already have a pretty large team at Stanford that sees and treats folks with these genetic abnormalities. And as you heard from Angela earlier, the theme here is teamwork. So we actually have a pretty large team of nurses and genetic counselors and adult and pediatric physicians who see these conditions day in and day out. So we all work together to treat these conditions. All right, thank you very much for your time.
Thank you very much, Marco. So I think as the speakers so far have really nicely illustrated, we're really proud and privileged to be part of a team where a lot of really cutting-edge work is being done in heart rhythm disorders. The genetic work Dr. Perez just discussed, together with new advances that really Stanford's at the forefront of, both for isolating pulmonary veins, firm ablation, and other approaches. And Linda Norton is our next speaker, who's really coordinating the future therapy aspects of our group. Linda did her PhD studies at Yale and is now really leading up the coordination and direction of a whole host of studies in many different heart rhythm disorders. So thank you very much, Linda.
All right, I need everybody to wake up. If you need to move, if you want to stand, that's absolutely fine. We want to make sure we have enough time for questions. So how much time do I have? 10 minutes.
10 at the most.
Perfect. Okay, so I'm going to go quickly. You're going to have to let me have a little discretion in what I address with you, and I'll pick the important parts, the most cogent parts of this. So we have quite a few arrhythmia studies, and these studies, I want to tell you why we pick them, what ones we're recruiting for, and what you might find as the rewards of being part of our studies. There's a long list there. You'll see that our studies are captured around different populations. Paroxysmal AFib is in the upper left-hand corner, which we've all addressed. Persistent AFib that kind of stays there, doesn't go away, is in the upper right-hand corner. We have quite a few outcome studies. We have cutting-edge studies, of which those are sort of the groundbreaking studies. We have a lot of device and imaging studies, and Dr. Narayan gets his own bubble because his studies are both cutting-edge and extremely important to how the world of AFib ablation will change. Reasons we do research, new technology. We want, as an academic institution, to be able to offer you the greatest, the best, the most novel, the most cutting-edge studies that we can offer. And we want to advance science. So to that goal, we want to make sure that what we pick in terms of research that goes on with all of our faculty is that it benefits patients. We want to pick studies that are offered at a few sites so that we can advance science. We want to do first in man, and for the women in the audience, you'll smile and say first in women's studies as well. We want to improve and inform how we practice, always. That's how all of us think. So for the new technology, the only one I really want to talk about in this slide is Avera and Enmark. And Avera, because Dr. Park opened the door to ventricular tachycardia and ventricular fibrillation, rhythms coming from the lower chamber of the heart, we are involved in one very cutting-edge study right now that is a defibrillator. And it is a very specific one. It is one that will allow us to do MRI imaging safely. So we're involved in the data collection for the first part of this study, and I don't even know if Marco knows this yet, but we will be doing the continued access to this study as well. So because we were one of the 10 or so centers, they are saying, before it gets FDA approved, make sure you can continue to use it in your patients. And so that's what we're going to do. And I know that there'll be a few people who will want to, we'll definitely have patients who will work well in this study. It's a picture of the imaging. And what we do during the MRI now for the first part of the study is we're doing test MRIs. We're checking devices to make sure they're working well, and we're collecting lots of data. What we're going to do in the continued access part of it is way less, and it'll probably last only for about a year. I want to talk a little bit about Enmark because we are enrolling for this study, and it is the PV isolation portion of ablation, and it is with a company that has two different shapes to a catheter that they use to do PV isolation, although you can do touch-ups as well in other places in the heart. Recruitment. We're currently recruiting for quite a few studies, so I do think it's important for you to know about the ones we're recruiting for. Cabana is one of them. It's a comparative effectiveness trial for AFib ablation, medication versus ablation, and looking at outcomes, lots of outcomes. Number of variables in this study is remarkable. It's been going on for about 5 years. We know something about the data. I hope that we will know lots more over the next few years, and we may already know mostly the answers to this because it's been going on for quite a while. We have about 6 patients in that trial, And we're looking forward to the end of enrollment probably by December of this year. And Mark, I already spoke about. Adaptive response is beginning now. So this switches gears a little bit again to that population of patients who have defibrillators in their chest. And in particular, a special kind of defibrillator because they meet the criteria to have resynchronization therapy as well. So they have to have a big left bundle. They have to have a need for treatment of their heart failure that meets certain criteria. And we're going to use a special kind of resynchronization for this study where we essentially do echo optimization constantly within the device. And we're going to do it as a randomized trial. It's adaptive is on or adaptive is off. The bottom study is the one you're going to like because it's easy and it makes sense. It's a music study. And so this is a study that was prompted by Linda Ottoboni, myself, and David Pickham. And what we're doing is looking at EP patients who are receiving conscious sedation. And we said, hey, can we make this better and have people less anxious, maybe have better outcomes, and give them music during their procedure? So we're in the midst of recruiting for that study now, and we're redesigning it a little bit. It'll be 2 treatment groups. One group doesn't get music, the other group gets music, and then we have outcome variables. So I see smiles. I think you get that one.
Do they get to pick the music?
Yes, you get to pick the music. That's a great question. So we're using Pandora, and what we did is designed it so that you could pick your genre. I like country, I like jazz, I like rock, but no heavy rock, because we know heavy-duty techno rock will probably increase catecholamine, which we don't want to do during the procedure. So we pre-populate the music, you pick the genre, and then that's the genre we play. Isn't that cool? I like that too. So Cabana I've already told you about, and adaptive I've mentioned, and music I've mentioned, so not bad. I was trying to be brief. So I want to go to rewards. Why should you even participate in a trial that's offered? And so I've taken patients' responses to being in a clinical trial. They get to receive a treatment that's not available elsewhere. So commonly people will say, I feel really lucky that I got, for example, this Avera MRI-compatible ICD, or I got this other treatment option, for example, music, because I think that music study will actually allow us to give music all over the hospital, to the OR, to families, if we can just show that it has such beneficial effects. Other people will say, I get to contribute to science. There's an altruistic element to being in a study where you say, I'm open to either of these treatment options and let me be involved in this study because I can allow that randomization to be decided by a given flip of a coin. And the following, which is the part that is the most fun, is that you get followed very closely when you're in a trial. So that means you get all of this lovely team, but you also get all of the research personnel. And a few of our patients get very misty, especially when it's a long-term trial. They've been involved in it in 2 or 3 years, and we say, okay, we're going to transition your care over. I'm not going to collect data on you any longer. And they get a little teary-eyed and say, but will you still come see me? Of course we'll come see you. So we have a few up-and-coming studies, but what I wanted you to do is know that there are many places you can find out about clinical trials. Dr. Narayan mentioned Stop AF, but there is a website, stanfordhealthcare.org, and there is a med.stanford.edu. There's also clinicaltrials.gov. And if you come to our clinic, we have brochures that are a synopsis of all of our studies that are currently available. So there's lots of resources. And we have a very broad group of people who are all working on various aspects of your care and research. So it's a long list, some of which are here, and all of us are involved in research at some level. So I welcome you to hear more about this. Thank you.
Thanks, Linda. I think that was really fantastic. Just mics? Perfect. So, oh, you're doing mics instead. Okay, superb. So we're going to take questions from the audience now to any of the panelists, or actually on related questions or questions directly related to the talks. Just put your hand up, and you can direct it to the group as a whole or to a specific individual.
Is there a Stanford website that contains the contents of these presentations?
Linda?
So, I don't know. Would you know that? Angela?
I don't have the, we don't have the content. Are we going to post? I don't know. We're going to find out. How's that?
I think there was a syllabus, wasn't there, because we sent the slides ahead of time. We will. That's an excellent point. So we will make sure. The question was whether there's a website, and so we'll make sure that they're available.
Yeah.
To be announced later.
Does the lady there have the answer? Fantastic. Good. So that reminds me. Please feel free to read the brochure and fill out the evaluation forms.
I'd like to find out the absurdity of the catheter, is that inhibited, or if you have any stents, a lot of stents? I have a large population of stents, and I'm just wondering if the catheter can still be inserted and used for development.
So I guess I can take that one. So stents can be placed in different parts of the body. Typically, they're placed in the coronary arteries. There are other sites they can be. And so when we do ablation procedures, or even when we do implantation of pacemakers and defibrillators, we typically do not go anywhere near the coronary arteries. And therefore, it won't interfere physically. I guess a related question is, can the energy from the catheter disturb the stent? And typically not.
I'd like to know, what does the sick sinus syndrome indicate? That's what I was diagnosed with at first. I now have a pacemaker, but
Anyone want to? Shirley?
Hello? So sick sinus syndrome. So the sinus node is basically the medical term for your biological pacemaker. This is the part of your heart that sets your heart rate at any given time. And it responds to adrenaline, it responds to the calming nerves, and varies your heart rate through the day and gives you more heart rate when you need it and slows down when you don't need it, like when you're sleeping. So sick sinus syndrome essentially just means that that biological pacemaker, the sinus node, just gets sluggish and isn't as, first of all, just at rest, can get slower and slower and slower, and also doesn't tend to respond as briskly as it used to or as it needs to keep up with your body's demands. That's pretty much it. And there's a whole slew of indications for when you need a pacemaker for sick sinus syndrome or not. So.
And I think I'd just add that the pacemaker is very good treatment for that. And for instance, the DMV would consider a pacemaker a complete cure for that condition. So,
my question to Dr. Park. What tests show that the signal comes just from the bottom part of the heart? How do you know? When you look at the EKG, how do you know that the signal comes from the bottom part?
Oh, from the EKG, how can you diagnose ventricular tachycardia or a PVC? Well, it has to do with knowing what a normal morphology or normal shape of the EKG looks like when you're in normal rhythm. And there's certain features of an electrical activation from the bottom chamber of the heart. There's sort of hallmark characteristics on the EKG that tell us that it's from the bottom chamber, and that's how we'll know. Even an EKG, though, is not necessarily diagnostic. Sometimes it is not clear whether it is necessarily a bottom chamber rhythm or a top chamber rhythm that's just going very fast. I guess ultimately the only way to really know and diagnose is with a catheter study where you put a catheter in the heart and get the signals directly from inside the heart, and then you can know exactly where it's coming from.
I have a question. Is a higher diastolic blood pressure associated with AFib?
Sorry, sir, is a higher diastolic blood pressure? Was that your question?
Yes, correct.
Yeah, so,
Thank you.
So one of the most important risk factors for atrial fibrillation is high blood pressure. So what we know is that if you take everybody and we look at patients who have atrial fibrillation, almost 40% of patients have high blood pressure. So we know it's very, very important. Now, there are a few components of the blood pressure. There's the systolic blood pressure, and that's the top component, and the diastolic blood pressure, and that's the bottom component. And it has to do with how much at what point your blood vessels relax. And what we do know is that both components, the systolic and the diastolic blood pressure, are related to atrial fibrillation. It's hard to separate the two because the two go hand in hand. So when you see a higher component, you almost always see a higher lower component as well. But to answer your question, yes, there is a relationship between diastolic and blood pressure and atrial fibrillation.
And I have one other question. How much time in the hospital for catheter ablation?
Sure. How much time in the hospital to undertake a catheter ablation? Usually, we bring an individual in the same day, that morning of the procedure. We perform the procedure at least one night because we feel that the procedure itself is a few hours, and we'd like to monitor the patient after the procedure. But by and large, we're able to discharge the patient the next day. Sometimes during the procedure, the catheter tip itself, in order to deliver the energy, we extrudes a little bit of fluid at the tip to cool the tip to allow us to continue the ablation throughout. An individual will gain a little bit of fluid throughout the procedure, and we have to remove that fluid with diuretic treatments, and that may result in maybe another night in the stay in the hospital. But by and large, 1 or 2 nights in general.
Thank you. So you had a question?
Yeah, let's say your pulse is 65 and you're in the house. There's no activity of any physical kind, and all of a sudden your pulse goes to double, 130 or so. And it stays that way for a couple, 3 hours. I've had this happen to me in the last year 4 times. And it sounds almost like an electrical engineering, you would call it the relay bounce, if you know what I mean. Can you tell me what specifically causes this?
Can we have maybe Angela start off on that in terms of how you would, go about contacting the service, and then maybe somebody else can pick up?
It may or may not be abnormal. In the case you're describing, it probably is abnormal because it sounds like you're not doing anything during that time. So it's most likely an abnormal focus in the heart that generates this fast beat. But it would be very difficult for us to tell exactly what it is without doing a little bit more investigation. So you would need to be seen by a provider, and most likely we'll offer you one of the monitors I described previously, and that would give us a good idea of what the arrhythmia is. It helps us to know how it starts and how it ends, looking at the monitor and what it looks like during the period of monitoring.
Let me just say, have you run into this before?
Yes.
The pulse goes exactly double.
Yes.
We do see that.
Yeah, just a corollary to that. You bring up a very good point. We mentioned about atrial fibrillation, and one of its cousin arrhythmias is what's called atrial flutter, a very distinctive circuit. And Dr. Narayan showed that picture of that rotating motion around one center. Could this be where the upper chamber is generating a very regular rhythm at, let's say, another multiple of 130, 260, and at 65 you're just getting 1 for every 3 or 4, whereas when it doubles right to 130, then it's going 1 for every 2. So that's why the first step very, very often in your case would be to obtain an EKG, an electrocardiogram, to just see what your arrhythmia, and then there are times that abrupt onsets of arrhythmias can happen. And it may not be the upper chamber creating the arrhythmia throughout the time. So I think, as Angela mentioned, a monitoring study would be ideal. So, right.
So,
let's say that one has persistent AFib with few symptoms and you're on an anticoagulant. How and when do you decide to move to ablation? It wasn't clear to me. I mean, if you're relatively asymptomatic, there are long-term effects and so on. When do you decide to go for ablation?
it's a super question. I think this is really at the forefront of where we are. At the current time, we do AF ablation primarily for symptoms. So if somebody's really feeling great, even if they have AFib all the time, as long as we've covered our bases for anticoagulation, we can let that person be as they are. I think we like to control the heart rate somewhere in the 80 to 90 range, and then we're done. The real question is that person really asymptomatic? And sometimes we find that if you try to get sinus rhythm back, as Dr. Vishwanathan said, with a controlled electrical shock, people feel much better in regular rhythm. So there's that cusp of people who feel better. So when do we intervene? If somebody's truly asymptomatic, I personally wouldn't. My colleagues can weigh in. But if you have, maybe you've noticed you're slowing down a bit, then maybe it's worth a trial of regular rhythm to see if you feel better in regular rhythm, and then to try an ablation to make that permanent. So I think we've got time for perhaps one more question.
Yes.
Sir. And I'm sorry, for the other people in the audience, we are going to be around, so I'm sorry if we couldn't accommodate everybody. Go ahead, sir.
My question is specific to a skipped heartbeat. Can medication, I'm on atenolol, and I have a zero monitor attached right now.
So I'm sorry, could you speak, is the mic on, Jocelyn?
Hello?
Brilliant.
Okay. Once again, my question is specific to a skipped heartbeat. My question is, can medication, and I'm on atenolol, and I also have a zero monitor attached to me right now, can medication cause a skipped heartbeat, or can the skipped heartbeat be caused by a combination of this medication and over-the-counter medications that we normally take without question, like Tylenol or ibuprofen? Can these be the causes also of a skipped heartbeat?
So it's a little bit difficult to answer that question without knowing exactly what the skipped heartbeat is from. Again, the only way to really know electrically what's going on in the heart is to have some sort of rhythm monitor, either an EKG or one of the monitors, on at the time that you feel the skipped beat. The reason I say that is because, so atenolol, it can slow the heart rate down. It slows the electrical conduction in the heart down. And so if you have any underlying disease in the electrical system in the heart, the atenolol can exacerbate that and potentially cause you to skip beats or drop beats. That's a very different phenomenon from what I was talking about in terms of PVCs, where sometimes you might feel that as a skipped beat, but it's only because the PVC does not generate a good pulse. It's very inefficient at pumping the ventricles, the bottom chamber. And so when you feel your pulse, when you have the PVC, you don't feel anything. And then you only feel a beat when the next normal beat comes in, so it kind of feels like a skipped beat, but it's actually an extra beat. And in those cases, the atenolol can actually help. It's one of the medications that can actually suppress the PVC, and that in that case, the atenolol may actually prevent the skip beats from happening. So it's a little bit difficult to answer that question without knowing electrically what's going on.
Ladies and gentlemen, it's been a real pleasure being here with you today. I know the panelists, we've all really enjoyed being here. We hope you have as well. Please take a moment to get a brochure if you don't have one and fill out the eval. Let us know what you think, honestly, and we'll make it better next time. Again, thank you. I'm sorry if we couldn't accommodate your question, but we're going to be here for a while. So thank you very much and have a wonderful rest of the weekend. Thank you.